Good afternoon and welcome to today's IAC webinar, Quality and Safety in OBL and ASC Settings for Vascular Intervention. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. And now I would like to introduce today's guest presenters, Dr. Srinivas Rao and Dr. Carl Fastabend. Dr. Rao is the founder and medical director of the Texas Vein and Wellness Institute in Houston, Texas. For nearly 20 years, Dr. Rao has been in private practice in the Houston area as a diagnostic and interventional radiologist. Dr. Rao has served as director of radiology at many hospitals and imaging centers throughout the Houston area. Dr. Fastabend is a vein and vascular specialist at the Texas Vein and Wellness Institute, having relocated to Houston, Texas as of October 1st. Dr. Fastabend first opened his comprehensive practice in venous disease in 2011 with the goal of providing state-of-the-art care. His focus is on all aspects of venous disease, and he is recognized for expertise in the area of stenting large veins in the body for venous compression or obstruction. He also serves on the IAC Vascular Interventional Board of Directors representing AVLS. Both are true experts in the field, and we are pleased to have them with us today. And with that said, I will now turn this webinar over to today's first speaker, Dr. Carl Fastabend. Doctor?
Hello. It's an honor and pleasure to be here. I'm going to talk about the nuts and bolts of vein center or vascular center accreditation, how it's done, and give you some of the background into developing the vascular center protocol for the IAC. I have no disclosures. So there are standards that have to be met to be IAC accredited, and I'm going to go over them for a bit. And so what are the standards? For deep venous intervention, peripheral arterial intervention, and hemodialysis access intervention. The Vascular Center Accreditation, which is the newest accreditation that IAC has, involves all three of these or any of these. And we're going to go over the protocols. So just as an example, let's look at the medical director's requirements for a peripheral arterial intervention certification. Has to be board certified in his or her vascular specialty. And in the previous 3 years, this is cases that have been done. He has to have done 40 angiographic cases, intravascular ultrasound, 20 cases, if intravascular ultrasound is offered in his lab. 30 angioplasty cases with 30 stent placement cases for peripheral arterial accreditation in the past 3 years. If angioplasty and stent placement are done at the facility. Atherectomy, 30 cases, if atherectomy is done. Thrombectomy, 30, if performed in the facility. And thrombolysis, if aneurysm repair, endovascular repair is performed, 10 are required over 3 years. The director, this is all for the medical director. The medical director has to have ACLS certification and 30 Category 1 CME credits in vascular in the previous 3 years. Two hours of training in fluoroscopic radiation safety, which can be included in the 30 Category 1 CME credits. He is responsible for assuring compliance with the standards, radiation safety, outcomes, quality control, and appropriateness of care provided with documentation of the same. He will run regular QI meetings with case study review conferences for quality improvement. He is responsible for personnel interviews and significant facility operations. This is all to be documented. Now, to look at the medical director for the deep venous intervention, let's look at that. Board certified in his or her vascular specialty. Over the previous 3 years, have done 20 venograms 20 venous IVUS cases, venous angioplasty and or stenting, if that is performed in the facility, 15, pelvic venous embolization, if performed, 15 cases within the 3-year period for accreditation. IVC filter placement is 15, if performed in the facility. IVC filter retrieval, 15. Invasive treatment of DVT, 15 are required if it's performed. With treatment of venous malformation, 15 over 3 years. So it's important to note that the requirements for additional medical staff members, including other operators, as well as techs and nurses, the requirements are similar in terms of case numbers and CME credits needed. So everyone has cases that are required, that are operators. Nurses, so forth, don't, but they have their own requirements. Requirements for technical staff, medical physicists, advanced practice providers, and nursing staff are specifically noted. I can tell you that the IC has spent a great deal of time preparing the protocols for approval for the Vascular Center, and I participated on a committee that approved them, and we went over them meticulously. There was much discussion about case numbers and other requirements. So it's been looked at extensively over a prolonged period of time with consensus agreement. In addition, there are also exacting standards for the physical facility, safety policies, contrast administration, and fluoroscopy. There's a big emphasis on radiation safety, which is appropriate. Importantly, the quality improvement program of the facility evaluates all types of procedures performed on an ongoing basis with oversight by the medical director and a log available. So in conclusion, IEC accreditation allows owners and operators of an outpatient facility which is dedicated to vascular diagnostic studies and treatment to assess their level of performance and adherence to the high standards of care. The aim of the process is to lead to optimum outcomes with a high degree of patient safety. All of the requirements are listed in the IAC website and readily available. Thank you for your attention.
Good afternoon. My name is Vascular Rao and Srinivas Rao, and as she said, I'm the medical director of Texas Vein and Wellness. I don't necessarily consider myself an expert in this field. I think more someone who's went through this process and can show some insight into the process and how it works and how it's helped us in our center. So, I have no disclosures. A little bit of background also, like I said, I was part of a big radiology group and opened my first vein center about 10 years ago and saw the importance of the accreditation process in the vein space, and went on and pursued our accreditation through the IIC and have seen tremendous benefits on the vein side. And upon seeing that, we opened up. We had 6 vein centers, and we realized there's also a need for the OBL side, and so we opened that last year, and we were one of the first in the state to get this IAC accreditation for our OBL, because in large part because what we saw, what it did for us on the vein side. So what I'm going through is really the hows, like, what do you do? And we're going to go through each one. But the next slide, the first and foremost is commitment. So do not begin this process if you're not committed to this process. And because it's time and it's money. Time in the sense of gathering all this data, which we're going to go through in a minute. But it's also money, and not just the fees for the registration, but you're going to be spending a significant amount of manpower going through this. So you have to be committed. And part of that commitment, next slide, please, is the ability to identify a champion. So what we found on the vein side was that once we pick somebody to be that person, they were the ones that were able to follow through and stay on task, because it's a lot of work. And so what we ended up doing is setting that aside as some type of bonus structure where, you know, we go through that process, and they stayed on top of it along with their other normal day-to-day duties. But identifying that person who is going to be able to follow through is critical. And, you know, as myself speaking, I didn't have the time to do that myself. And so doing cases and growing my practice, so we had to find someone, and that was really critical in our success on the vein side. Next slide. Yeah, as Dr. Fastabend alluded, yes, you need to identify as part of this process who are going to be your medical director. May have more than one in terms of the different areas, and then the staff actually involved. Who are those staff members that will be identified? Because when the site visit, which we'll get to, comes up, that is part of it, that they will want to see the credentials for these people. Next question, slide. So begins with the questionnaire and that kind of application process. As those are all completed and then submitted, we are able then to, you know, you begin to see all that is needed, and that begins the process. Next slide. So the next process is really about gathering. Next is gathering the data. And in some cases, not just gathering, it's having to create data. Because what we found is, you know, we were missing things that we didn't know we didn't have, you know. And so through this process, we realized areas of our own deficiency, and we're able then to fill those voids with the appropriate materials. Next slide. So I don't, again, a lot of this is already available to you, but I wanted to kind of just go through highlights of areas that are important. So in terms of the important documentation that you're going to need to upload is the facility documentation, meaning the inspection logs of medications, the autoclave logs, recent physicist surveys, fluoroscopy checks, quality improvement minutes, and any kind of complication logs. And then part of the other uploading is going to be medical documentations on the patient or patients that you're going to be performing on during the site visit. And they're going to want, you know, the H&Ps on these patients and any pertinent imaging. Next slide. So, and then you wait, and then it's just a waiting game until you hear from them. It's not very long. You know, they're going to may or may not have certain deficiencies that are present, and you just fill those, and then we move on and wait for the site visit. Pick a date that's works with your schedule, and have those patients ready. So on the site visit day, I think the important points are pick a day and make it a lightened day. You don't want your full load of cases. You want to be able to take your time and be able to really have a day dedicated for this process. And so choosing the right patients is always, I think, critical, as we've seen both on the vein side and is finding the right patients that are understanding and willing to participate in this. And then the next part is having all those policies and procedures ready, because they're going to want to see those when they come. They're going to want to go through those process, and it starts with the physical facilities. So in terms of physical facilities, in terms of the space, are there emergency exits, appropriate bathrooms, the procedure rooms, or are there storage, or maintaining confidentiality of patient records. They want to know about medications, where are they being stored, and expiration dates on these, emergency supplies, oxygen, simple things like flashlights, batteries, AEDs. It's a checklist. And so that's, again, where that champion is going to be checking each box and each list. And because they're going to want to see all of these, and that you have these, and that they're not expired, and they're in an appropriate place. So again, these are lists that you can look, but I'm just emphasizing it's extensive, but it's thorough, and that's what you want. Again, I mentioned about AEDs, oxygen supplies, monitoring devices. Very specific requirements are listed in the autoclaves, and like I said, all of these things, are basic and are already happening, but it's just having them in a organized structure. In terms of the Dopplers, ultrasounds also, and then facility safety. So in terms of facility safety, you're going to have the radiation aspect from the fluoroscopy unit. So the staff all have to be exposed, monitoring their exposures, and having a physicist review these on a routine basis. And, like, for example, even knowing who's pregnant, who's not pregnant are part of that process. And something we learned also on the vein side was that that was one process that we hadn't really thought about. And majority of our patients are on the older side, but, we realize we need to be doing a routine pregnancy test on certain patients are getting sclerosing agents, for example. Contrast, how is your contrast being kept, and adverse reactions, and having the emergency equipment for that. We touched on fluoroscopy a little bit in terms of the training and the monitoring. Certain required hours need to be logged, as well as continuing education in that area. Can be done online, but it definitely needs to be maintained through CE hours. And of course, patient radiation doses as well are all monitored. We have monitoring outside of the lab as well. And so just basic guidelines, a lot of them state regulated, but they need to be followed and documented. Let's see. Quality control documentation, again, something we weren't doing a lot of before, but now it's involved in all of our centers, is documenting all of these parameters in a very clear and organized, in an organized manner that are readily available upon even asking. QI and quality improvement is again something we never did, and it's part of the process. That's what makes us better, is how do we maintain our complications. And before, if I had an E-hit or some type of venous issue, just okay, yeah, well, that was an E-hit. But it's this now being able to document and realistically look at what percentage and what are they happening from, and has made us a much better practice. And I see the same on this is on our OBL side. And ASC is going to be helping us track these things that are really important in improving our patient outcomes. So that has been really a good addition to our practice. Again, general measures of what we determine as appropriate procedures, inappropriate procedures, and kind of keeping a tab on those. And safety of the patient, technical performance, and as well as medication checks. Like I told you, I think the quality improvement meetings, which go on or twice a year, are a minimum. We have one every quarter. Have been extremely helpful in our documenting and monitoring, especially as we grow. It's We have now currently 8 providers with us. And so if it's just one, it's really simple. But as you grow, to be able to monitor these multiple providers is critical. And then again, documenting all of that. And then there's the administrative side, which is already being done in most of these practices: confidentiality, patient complaints, and retention of these records for minimum. We keep them for 7 years. So those are the kind of the hows and how to get about it. And then the last thing, I think, which is probably the harder part, is to really understand why. I mean, the hows are a checklist, and you go through and you complete each one and you move on. But the bigger question is why? Why go through this process? And again, I can only speak from my experience. Again, I'm not an expert in this area, but I'm a guy on the ground doing cases and building centers and realizing the importance of this entity, of this IAC accreditation. And that's what I really wanted to talk a little bit about, is why go through the steps. And there are many reasons. I mean, some more important than others, but it is the only CMS approved accrediting body that brings a certain amount of validity and in compliance to the industry standards. Like I said, as Dr. Fastabend alluded to, these guys have spent hours going through what are the things needed and important in a practice, and what is the industry standards. And I found that by going through this process made us better. We found areas where we were deficient and allowed us to improve. There's ample tools available through the IC, such as webinars and self-assessment tools of how your practice is doing. I found them extremely helpful. And, better reimbursement, that's kind of vague, but I've seen it in a couple aspects. Because we are doing things in a standardized way, we're not getting the denials. We're not getting the rejections because we've checked all the boxes. And what I've also seen, for example, on the vein side, is this push that payment related to accreditation. It happens already in Massachusetts with Blue Cross on the vein side. And I think there was an attempt by Aetna to get something similar nationwide with accreditation, paying only accredited vein centers. And I don't know, I think people feel different ways about it, but if you look at it, I see a lot of the space as the Wild West. In other words, in the vein world, for example, we have anesthesiologists doing vein procedures, cardiologists, family practice docs doing vein procedures. So there's no standardization of how these are being done, because they're being done in their own offices, versus in a hospital, there's a whole process to go through. So that's what I see, is this gives a level playing field, is that these are the criteria. This guy's done X amount of cases. Their radiation safety has been checked. And so I feel like for us down the road, reimbursement is going to be tied to this process, and that's why I believe so strongly in it, and I'm trying to get all of our centers accredited. Another point, obviously, it satisfies some of the MIPS as part of the quality payment plans. We have seen some cost reductions as we gone through this process and eliminate certain things, not just techniques that may have helped us reduce time as well, which is money, and improved our patient outcomes in the process. I think that has been extremely helpful. And at the end of the day, it is truly about the patient. And so our patients feel very comfortable as they go through this process and see all the checklists that we go through for their outcomes. Like I was alluding to, the commitment to quality improvement is something that was really has helped our practice tremendously. That was not part of our practice in monitoring our complications and tracking them in follow-ups, procedure selection, appropriateness of them. And so it's helped us create a standard that we're able to follow. And finally, I mentioned about marketing, and that's another broad term. But the consumer today is not the consumer of yesteryear. They're very intelligent. They understand about the credentialing process. Accreditation. They know their auto mechanic is accredited in fixing certain types of vehicles. So it's a logical transition that you'd want a clinic that's outside of a hospital to have a certain amount of accreditation in that field. And so when I'm out marketing and talking to different referring physicians, I've often led with the fact that we are an accredited center, and that's what separates us from others that are not. And many of them are good. It's just that they don't have that. They haven't gone through that process, which is, again, as the very first slide is about a commitment and willing to spend the time and spend the money to get this done, so that you are acknowledged for that you have all your ducks in a row as best you can. And I think what we've seen in the vein side, it has tremendously helped us from a marketing standpoint to grow. We've gone from 1 center to 6 centers. It's not all due to the fact that we're accredited centers, but it's a part of it. And that's why I feel like trying to spread the word about this is going to be helpful for our whole space, because I think everybody's aware there's, some inappropriate studies being done and treatments being done. And so if we can get a standardization, this is going to help us for all of us in the end, which will lead to, I think, stop this continued decreasing reimbursements on these procedures, because I think there's a lot of overuse. So that's my take on that. Again, I'm not an expert. I'm just someone out there doing this on a daily basis, and what I found to be helpful for me. Thank you.
Hey, thank you very much, Dr. Rao. And at this time, we will begin the Q&A session. From IAC, I'd like to introduce Laura Humphreys, Director of Accreditation for Vascular Interventional, and she will assist with the Q&A session today. Laura, would you like to start us off?
Thanks, Kelly. And thanks, Dr. Rao and Dr. Fastabend, for wonderful presentations. We do have a few questions here, and I guess, we have 2 speakers on the line, so I'll kind of throw them out. If you have, whoever wants to answer is fine. And then I guess I'll give, everyone a chance to put in their input if there's, more information. The first question, and I think this is going to be the burning question of the day, assuming that your facility is already accredited through AAAHC, is this a complement to that current accreditation?
Carl, I'll let you handle that one.
I'm just a big believer in the IAC accreditation. When I was looking at relocating to Houston over the past year, the fact that this practice had multiple IC accredited centers was the most attractive aspect of it. I think that's becoming more and more important, and it made them stand out in my mind. So to me, IAC accreditation is the important accreditation.
Yeah, and my 2 cents is that if you look again, like I alluded to with Blue Cross in Massachusetts and this Aetna came up, they were referring to IC as the one they want to see. And so I feel like if you're going to choose one, that's the one that seems to be the one gaining the most traction out there and people recognizing.
Great, thank you. So kind of a follow-up to that, you've been through the accreditation process. What was the one thing that the IAC identified in your facility that may have been a deficiency that maybe surprised you a little bit?
For us, I think it was really the tracking of, like I talked about earlier, the tracking of complications, or that's not something we did. And I found that, again, to be extremely helpful for us to identify our mistakes, and are they at a certain location? Is a certain provider? Is it, and then really made us better. So that was something that weren't, when you're in the real world doing practice, you're not necessarily logging everything that I got a E-hit, I got a complicated, I got a DVT, and you just register in your brain, versus actually taking the time and documenting it in a place that we can all come back and review. Was I think one of the biggest things for me in terms of helping our practice.
Great, thank you. Let's see. How long would you say it took you to get all the materials together and get ready to submit your application?
Yeah, that's a good question, and it's related to the first thing I told you, is about identifying the champion. When we first did one of our vein centers, we didn't have that champion until midway through, and it took us 5-6 months. But the next time we learned, and the next center we accredited, we did, and it was in less than 3 months. I would say 2 to 3 months, and our OBL took us 2 to 3 months. So I think 90 days is, once you're committed, and just I'm committed, you fill that, it's a 3-month process that you'll complete.
Great. And, I do get this question a lot at the IAC, and, what I normally tell people is it just kind of depends on where your facility is, how long you've been in business. Do you already have those protocols in place? I mean, some people might be starting from square one. Some people might be, almost to the finish line. And it certainly gets easier as, you go through a reaccreditation cycle. Once you kind of have everything done, if you play by the rules, usually it gets a little bit easier after that.
Right.
I was going to throw in there, going by Laura, the input that I've gotten from the reviews of the vein centers that you've been to, and vascular centers that you've been to, that report to us that have to be voted on for accreditation, is that people get dinged all the time, and they get dinged on the very simple things that really they just stumble their toe on. Unsigned ultrasound report, or inaccurate ultrasound report, or just very simple paperwork sort of things that should really, those issues should have been ironed out long before the application process. And I think that's just an example of, it shows that, hey, there are things that we can all do for better and more effective care to patients, and documentation is very simple. Don't you agree, Laura?
Absolutely. Yeah, for sure. I mean, we do. And, unfortunately, we see that a lot. People, even if they're going through a reaccreditation cycle, they'll, have all these small deficiencies that really should have been ironed out in the beginning. But, I think, well, this goes into my second question that says, why should we continue it once we already have it? And, what we do find is, people just get complacent. You're getting this accreditation, you're making sure all your T's are crossed and your I's are dotted. And then, as you go, you just kind of go back and you kind of fall into these bad habits that you don't even realize. So I think that's really.
And in addition, just a little, in addition to what Carl was alluding to about, like, for example, the signing of an unsigned ultrasound report, yet if that got billed, that's considered fraud, in the sense you have an unsigned document that you've now submitted a bill for. So these are where this process of going through and making sure you have these checks keeps you not just growing practice, but keeps you out of litigation, because you potentially violate many laws by submitting a billed ultrasound report when it hadn't even been signed. So that's how we get better, is through a process like that ensures that you're doing these things before you do that.
And I think that's one of the reasons why I'm so excited about our vascular center accreditation protocols that have been developed in the past year. That is going to offer the opportunity for dramatic improvement in patient care, in my opinion.
Yeah.
So you talked a little bit about the application process, and you referred to the site visit. What is the general timeline for accreditation from the time you submit to the time you get granted?
From the time the initial submission of the application,
Yes.
yeah, I think it's 3 months. 3 months by the time we're done. A lot depends on the site visit variability, but then there was COVID for a little while where I think we did it through telemedicine, teleradiology, or whatever you would call it, but Zoom. But yeah, I think all said and done, it'll be around 3 months by the time you're accredited.
Now, as far as the site visit, is that a surprise visit? I mean, does the IAC just show up on your door and say, "Hey, we're here to watch your procedures"?
No, it's just the opposite. It's a very controlled. It's yeah, we're always nervous. You're performing, and so you just get back to what you're doing, and just like no one's in the room, and it's fine. But yeah, it's a little nerve-wracking. But they make it very simple and easy. They're very kind. They understand we're a little nervous and anxious, but we all agree on a date, and we get to pick the patients. And so it really is a very benign process. And they're just like a fly on the wall, just watching, and they're there for as many cases as you want. We chose, I think, 3 cases, and try to get a representation of the cases that you're going to be doing. We had an arterial case, PAD, we had a deep vein, and we also had an embolization case, I think. So, in choosing those right patients, as I talked about earlier, is critical. The patient that's calm and understands we're going to have multiple people in the room. So it goes very smooth, very smooth.
Do you see value in facilities, hospital-based facilities, trying to obtain accreditation through the IAC?
I think there's definitely that's a benefit to the hospital if they're trying to build a successful ASC and OBL. It behooves everyone to work towards accreditation.
Yeah, I mean, I think it'd be great because they already meet a lot of the standards through their own internal processes. So I think it would be an easy next step for them to get that IC accreditation. I've never seen it. Maybe you guys can tell me. I don't know of any hospital that's accredited, at least in the vein and the OBL section yet. But again, I'm not quite sure the reason why, but I think it would be a great next step for them.
Majority of our facilities are outpatient, but we do have, at least for vein center procedures, we do have some hospital-based vein center practices. We don't have any for the new modalities yet because they're brand new, but we do have some hospital-based vein center accredited facilities.
Great.
Let's see. One more question about the site visit. Sorry, I kind of skipped over this one. This listener is concerned about the reluctance of a patient to have a site visitor in the room. Have you experienced any problem with the IAC coming in and your patients feeling uncomfortable?
No, and that's part of that screening process. So for about a month before the actual site visit, we begin identifying those patients. So for example, if we did a procedure on the right leg, and they were great, they were calm, and they were easy and laid back, and we approached them and say, listen, we've got a case in 2 weeks, 3 weeks. Do you mind if we do the other leg with them? We're going to have some observers, and they say, no, we're fine. I mean, so it's again, spending the time on the front end. Again, it's your choice. It's not a random show up. And so you spend the time picking the right patients from your patient pool and find the one that you'd think would be pretty amenable to having someone watch. So everyone we've picked were amazing. We gave them a little gift card to Starbucks or something, but just for the little inconvenience, and so it was fine. We've never had any issue with the patient.
Okay, I have a question, and we might have to get back to this listener, and if we do, just please let me know. This has been asked a couple times. This facility does thrombectomy and filters. They're not supported by our providers outside extreme and rare circumstances. Now, I don't know if I'm pronouncing this right, but does ProTrieve count as a filter, or does it need to be a permanent filter?
I don't know how you would categorize ProTrieve, but I think the normal temporary IVC filters that you put in would count for sure, along with the permanent ones. But the ProTrieve in doing a filter in a thrombectomy procedure for protection, I think should count, but I can't speak for the IAC on that topic. I'm not sure we've covered that, Laura.
Okay. So this kind of is a follow-up question. I mean, all these standards, like, for instance, the deep vein standard, it lists all these procedures. It has IVUS, angioplasty, treatment of pelvic vein reflux, IVC placement. Do facilities have to do every single one of these procedures in order to qualify for accreditation?
No, it's only if performed in that facility.
And what would you say the most common procedures are? Let's just say for deep veins, since we're on a vein kick right now.
But it would be venography and IVUS and venous stenting. And lagging behind that would be things like embolization.
We have a question about all the different procedure areas. You introduced deep venous, peripheral arterial, hemodialysis, and it seems like a lot of people are really just familiar right now with our vein center. That's where we started with the superficial vein procedures. So they're asking, if they have vein center accreditation, why would they apply for the deep venous accreditation?
They're totally different, because now I have both and gone through both processes. So the superficial vein, it's a superficial vein accreditation. So it is strictly treatment of the superficial vein disease, great saphenous, small saphenous, perforators, accessories, using radiofrequency, glue, sclerosing agents. It does not extend in 1 centimeter towards the deep system. And so and truly that's the OBL setting. So I don't see too many people doing vein procedures in an OBL or ASC. Those are typically just in your office. So a totally different structure. Obviously, we don't need fluoroscopy and these other entities. So versus any kind of deep work is you're going to need the fluoroscopy. So they're really totally different. And so you're either in veins or you're in the deep systems, which require then 2 different accreditations.
Right, and this goes into another question. They were asking if there's different applications for each, and there's an application for superficial venous, deep venous, peripheral arterial, and hemodialysis access. Again, since I see another question about, hey, we don't do this, can we still apply? You don't have to perform all those different types of procedures in order to apply for the new 3 procedure areas, the deep venous. You don't have to do, IVUS, IVC retrieval, repositioning, venous malformations. You don't have to do all the laundry list. You definitely have to perform IVUS or venous angioplasty or things like that. There is a minimum requirement, but you certainly don't have to apply for all of them. But they are different applications. So if you're performing deep venous procedures, you're also performing peripheral arterial procedures, then those would be 2 separate applications. Now we would, we'd come out for site visit and we'd observe, both different types. We wouldn't really, we wouldn't break them apart per se, but they are two different applications. Let's see. What else did we have here? I think we're kind of starting to wind it up here. Here's a general question. How did IAC accreditation improve your workflow?
I think through efficiency, in the sense that everything seems much more organized. Because now we had to get everything in certain places and easily accessible. So I think overall it's just the ability to create a much more organized lab, where everything is very clearly labeled and identified as where to find them, where the stents are, where everything is clearly labeled and identified and close by. So I think it helped us in the flow of our data work, just because of the organization that was required.
And I think that adhering to,
book. Yeah, go ahead, Carl.
I was just going to say, adhering to standards such as go along with IAC accreditation reduces your complication rate, which helps your workflow.
That's right. That's a good point.
Okay, I have a question. For the medical staff volumes in the standards, do the physicians have to have performed those cases at the facility, at the applicant facility, or can they have performed them anywhere over the previous 3 years?
Laura, you better answer that one.
Yeah, they can be performed at, I know there's a couple of those on here that but I don't want to just jump in and assume and and answer them. But yes, for the medical staff.
Listen, Dr. Rao and I are happy for you to jump in.
Okay. So for the new procedure areas, deep venous, peripheral arterial, and hemodialysis, they don't have to be performed in the facility. The medical staff volumes can be performed anywhere, so you don't have to worry about that. Now, for the vein center application, I mean, the medical staff volumes also, yes, they can be performed anywhere, but we do have a minimum requirement of facility volumes for vein center. And we kind of just put that in because, as you know, vein centers were kind of popping up everywhere. So we wanted to make sure, they at least had a little bit of an established business before they applied for vein center accreditation.
I'm so glad you answered that question, Laura. That's a very good question and a very good answer. Even though I'm an IC board sitter, I didn't really know the answer to that one for sure. Yeah. Thank you.
Well, I think a lot of these questions are very specific to the standard. So I might go ahead and ask them, and I'll kind of put in my input. And if you want to add something, we can kind of work it that way.
Great.
Let's see. There's a question here. Does all staff need ACLS? The answer to that is yes. If you are performing moderate sedation, you do need to have, your medical staff member does have to have ACLS certification. Let's see. What if we don't meet the volume requirements for the medical staff? I mean, as long as you have a medical director that does meet the required volumes, then you can appoint medical staff as provisional staff for the 3-year cycle until they maintain their volumes. And I do think that's important to add as well. The accreditation cycle is 3 years. So, you apply, you go through this every 3 years. It's not, you don't have to do it every January, February, once a year, anything like that. You can apply for these accreditations simultaneously. Although it is a lot of work in the beginning, I kind of encourage people to do it. A lot of times if you stagger your applications, you'll feel like you're doing accreditation for the rest of your life. And nobody really wants to do that. Let's see what else. I'm trying to wrap it up here and get to these questions.
Well, someone was talking about volumes. What if we don't meet the volume requirements? And I think that's an interesting question, because what if they don't meet the requirements? And I think that leads to competency. I think at the end of the day, it's hard to get an accreditation if you haven't done the number of cases that is felt as a standard to be competent in that. And I feel like, that's not a number that that should be compromised. I think I think we have to get those numbers so that we can say that you have that competency and expertise in that area.
So I think we can probably start wrapping it up. I'm just going to kind of point to, some of these questions here. We have questions. Hey, where do we get the standards? Where do we start? All of that is available on our website at intersocietal.org. With the follow-up question is, hey, can you help me get the application completed? And the answer is absolutely yes. At any time, you can call the office. You can speak to myself or any of my colleagues, and we are happy to help you through the process. We have a lot of guidance documents online that you can absolutely use. Of course, you want to, read over them and make sure that they're, everything is, accurate. You do want to kind of make it personal to your facility, but you can certainly use any of those as guidelines. And then we also have a question is, hey, what's this going to cost me? Well, the new procedure areas for peripheral arterial, hemodialysis access, and deep venous, through the end of the year, which we're kind of wrapping up now. If you do apply by the end of the year, the accreditation fees are waived. And reason being so is it is a new program. So we are going to ask you to participate in a limited research study. And, we kind of hope, hey, we've launched these programs and we want to prove, that IAC accreditation, has value. So that's kind of why we're doing that. That is through the end of the year if you're interested in taking part in that. I think
my 2 cents on that. That's a great deal, guys. I mean, it is of added value. It makes your practice better. And I'm going to end on one comment for myself is that, I tout that we're the one of not two, maybe only IC OBLs accredited in Houston. And we're definitely there's only 4 accredited vein centers in Houston, and 2 of those are mine. But the point is, I'm here now talking to hundreds of people to come and join and make my competition even harder. But that's how good this product is I believe in it. And so, if I'm making my competition harder, but it makes the space better. And so that's why I'm so strongly behind this group.
Well, it says a lot about your motivation to that you have pushed the IC accreditation in your facilities the way you have, much to the credit of you and the entire staff in this great organization that I'm now happy to be a part of.
Thank you, Carl.
Well, I think that kind of wraps up all the questions. Do Dr. Rao, Dr. Fastabend, do you have any closing statements for us today?
I think that the best ones were just made by Dr. Rao, but I just want to say that I want to put a plug in for the IAC website. If you are really serious about doing this, I mean, you can go through that item by item, and it's cookbook there. It's there. All you got to do is follow the directions. And I mean, every time I look at that website, I'm impressed by it. So,
yeah, and I think another thing for me is, like I said, truly believe it, but I'm also willing to help. So it's like I don't mind. Lori can get my contact information. I can help them walk through some of the steps to go through it, and some of the pitfalls, and just we've done it. So I don't mind helping others go through this process. So.
Well, thank you so much. You both have done a wonderful job today on this, and I certainly appreciate your time.
Thank you. Thank you for putting it together. Appreciate that.
All right. Thank you. And thanks again, everyone. And a very special thank you to Dr. Fastabend and Dr. Rao for their presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. Once again, we thank you for joining us today and appreciate your participation.